Welcome to the deep dive. Today, we're zeroing in on chronic myeloid leukemia, CML.
Yep, CML.
Think of this as really getting the core info you need for revision. We've got some solid revision notes here.
Right.
And the plan is basically to pull out all the key stuff: definition, causes, risks, how it works, what else it might look like.
Investigations, treatment, the whole lot.
Exactly. Everything you need for a clear, sort of memorable understanding of CML. Ready?
Absolutely. We want this to stick. So a really clear, structured overview. Let's dive in.
Okay, first things first. What exactly is chronic myeloid leukemia? Let's define it.
Okay, so CML, in simple terms, it's a cancer affecting your myeloid white blood cells.
The myeloid one specifically.
Yeah, the myeloid lineage. And it's characterized by, well, the abnormal growth of immature myeloid cells. They just grow out of control in the bone marrow.
And there's often that genetic link, right?
Definitely. The big one is the Philadelphia chromosome. We'll talk more about that. But it's, really key. It's present in the vast majority of cases.
Okay, and how does it fit into the bigger picture of blood cancers?
It's classed as a myeloproliferative disorder. So myelo for myeloid cells, proliferative meaning overproduction. Makes sense, right?
Yeah, it does, overproduction.
And it typically goes through phases. There's the chronic phase, which can actually be pretty quiet.
Quiet, like no symptoms?
Often, yeah, or very mild ones. It can last for, say, 4 or 5 years sometimes, but then it can move into an accelerated phase.
Okay, accelerated sounds less quiet.
Right. You start seeing more immature cells, these blast cells, more basophils maybe, and treatment might not work as well. Resistance starts to creep in.
And after accelerated?
Then there's the blast crisis. That's the really aggressive stage. It progresses quickly and is unfortunately often rapidly fatal if not managed. Think of it like the disease speeding up and becoming much less stable.
Okay. Chronic accelerated blast crisis. Got it. And you said the Philadelphia chromosome is in most cases?
Over 90%, yeah. Some sources even say over 95%. It's really the hallmark.
Which brings us neatly to the cause, the etiology. Why does this happen? You mentioned the Philadelphia chromosome.
Exactly. The fundamental cause, the driver, is a genetic change. It leads to this thing called the BCR-ABL1 fusion gene.
Okay, BCR-ABL1, how does that form?
It's down to what's called a reciprocal translocation. Basically, bits of 2 chromosomes swap places.
Swapping places. Which ones?
Chromosome 9 and chromosome 22. A piece of the long arm of 9 breaks off and sticks onto 22, and a piece of 22 moves over to 9. It's written as T922, Q34, Q11.
Right, T922. I remember seeing that.
And that swap creates the Philadelphia chromosome, which is actually a shortened chromosome 22 because the piece it got from 9 is smaller than the piece it gave away.
Ah, okay. So the Philadelphia chromosome is chromosome 22, just modified.
Precisely. And the really crucial consequence is that the ABL gene, which was on chromosome 9, gets fused right next to the BCR gene on chromosome 22.
Creating the BCR-ABL fusion gene.
Exactly. And this new combined gene cuts for an abnormal protein, specifically an abnormal tyrosine kinase.
And why is an abnormal tyrosine kinase bad news?
Well, tyrosine kinase are like signaling molecules in cells involved in growth and division. This BCR-ABL1 is hyperactive. It's permanently switched on.
Like an accelerator pedal stuck to the floor.
That's a great analogy. Yeah, it constantly tells the myeloid cells to grow and divide without the normal checks and balances. It drives that uncontrolled proliferation we see in CML.
And do we know why that initial chromosome swap happens?
That's the million-dollar question. In most cases, the exact trigger for that initial translocation isn't fully understood, just that it happens, and when it does, creating that BCR-ABL gene.
You get CML in over 95% of cases.
Exactly.
Okay, so a very specific genetic event. Are there things that make that event more likely? Any known risk factors?
There are a few. High doses of ionizing radiation exposure is a definite risk factor. Think, atomic bomb survivors or major radiation accidents, not standard X-rays.
Right, high doses.
Yeah.
What else?
Having a history of certain other blood disorders like myelodysplastic syndrome or polycythemia vera might slightly increase the risk.
Okay.
Age is a big one. CML is much more common in older adults. The median age at diagnosis is around 60, maybe a bit higher depending on the study.
So not typically a disease of the young.
Generally not. It's quite rare in children. And finally, it seems to be slightly more common in males than females, though not by a huge margin.
Okay, so high-dose radiation, some previous blood disorders, older age, and male sex.
Got it.
Now let's dig a bit deeper into how that rogue BCR-ABL protein causes the problems of pathophysiology.
Right. So as we said, this BCR-ABL1 protein is a hyperactive tyrosine kinase. It activates multiple signaling pathways inside the myeloid
The
cell.
pathways that control growth.
Exactly. It ramps up proliferation, making the cells divide like crazy. But that's not all. It also messes with apoptosis.
Apoptosis programs cell death.
Yeah, the cell's natural self-destruct mechanism for old or damaged cells. BCR-ABL1 inhibits apoptosis. So not only are too many cells being made, but the abnormal ones aren't dying off when they should.
Ah, so it's a double whammy, too much production, too little removal.
Precisely. That leads to this massive accumulation of myeloid cells, both mature and immature, piling up in the bone marrow and spilling out into the blood.
That makes sense.
Yeah.
Okay, so if someone comes in with symptoms or blood results suggesting this kind of picture, what else might be on the list? The differential diagnosis.
Good question. You always have to consider other things. Other types of leukemia are definitely on the list, like acute myeloid leukemia, AML, or acute lymphoblastic leukemia, ALL. They also involve abnormal white blood cell growth.
Right.
Then there are other myeloproliferative neoplasms the broader category CML belongs to. Things like polycythemia vera, which is too many red cells, or essential thrombocythemia, too many platelets. They share that overproduction feature.
So other related bone marrow disorders.
Yes. And sometimes you even need to rule out simple reactive conditions. A severe infection or major inflammation can cause a temporary sharp rise in white blood cells, a leukemoid reaction that might initially look a bit like CML on a blood count.
Ah, okay. So infection or inflammation could mimic it initially.
Yeah.
Makes sense to rule those out. What about how common CML actually is? The epidemiology.
In the UK, it accounts for about 15 to 20% of all leukemias diagnosed in adults. So it's significant, but not the most common type.
And incidence. How many people get it each year?
It's around 1 to 2 cases per 100,000 people per year, relatively low overall.
Okay. And we mentioned age already.
Yeah, much more common in older adults. Pretty rare in kids. The median age at diagnosis, some recent figures put it around 72 years in the UK, so definitely tends towards the older population.
Okay, 72. Got it. Now let's talk about what might actually bring someone to the doctor. What are the typical clinical features? How does it present?
Well, especially in that early chronic phase, it can be quite insidious. People might just feel generally unwell.
Vague stuff.
Yeah, like fatigue that doesn't go away, maybe some weakness, losing weight without trying, night sweats. Bone pain can happen too.
Okay.
Because it affects blood cells, you might see signs related to low counts of normal cells. So, more frequent infections because the functional white cells are crowded out, pale skin and shortness of breath from anemia.
Right, the anemia effects.
Easy bruising or bleeding because platelet function might be off, even if the numbers are high initially.
And what about more specific signs?
A really characteristic one is abdominal fullness or discomfort. That's often because the spleen gets enlarged splenomegaly. It's working overtime trying to deal with all the abnormal cells.
So a big spleen is a key sign to look for on examination.
Absolutely. Marked splenomegaly is very common. Abdominal discomfort often goes along with that.
And you mentioned the typical age is 60s, 70s. What about blood tests? What would they show?
You'd typically see a high white blood cell count, particularly increased granulocytes. Platelets can often be high too. That's thrombocytosis. And interestingly, an enzyme called leukocyte alkaline phosphatase, or LAP, is usually low in CML, which can help differentiate it from those reactive conditions we mentioned, where LAP is usually high.
Low LAP score. Okay, that's a useful clue. And without treatment, it can get worse.
Yes, it can progress. Most commonly, about 80% of the time, it progresses to AML, acute myeloid leukemia. Less often, maybe 20% of the time, it can transform into all acute lymphoblastic leukemia.
So it turns into a more acute, aggressive leukemia.
Exactly. But the good news is many people, maybe 85–90%, are actually diagnosed while they're still in that chronic phase.
Oh, really? How?
Sometimes it's just picked up incidentally on a routine blood test done for something else entirely before they even have major symptoms.
Wow. Okay. Any of the less common signs?
You might get pain in the upper left abdomen from the spleen, maybe enlarged liver, hepatomegaly, sometimes swollen lymph nodes, though that's less typical than in other leukemias. The anemia can cause signs of hyperdynamic circulation, like a bounding pulse. Fever can occur, gout is possible because of the high cell turnover releasing uric acid. And very rarely, if the white cell count gets incredibly high, you can get hyperviscosity syndrome.
Hyperviscosity, thick blood.
Yeah, the blood gets too thick, causing things like visual disturbances, confusion, stroke-like symptoms, even priapism. That's a medical emergency.
Okay, that sounds serious. You mentioned a mnemonic earlier for symptoms.
Ah, yes. For some common initial ones, you can use few bands. Fatigue, easy bruising, weight loss, bone pain, abdominal fullness from the spleen, night sweats, and shortness of breath from anemia.
Few bands. Okay, that's helpful. So if you suspect CML based on these features, what investigations do you order to confirm it?
Right, confirmation is key. First step is usually that complete blood count, the CBC. It shows the high white count, the mix of cells, including immature ones, maybe the high platelets. It gives you a strong suspicion,
But it's not diagnostic on its own.
not definitively. For that, you generally need a bone marrow biopsy and aspirate.
Going into the marrow itself.
Exactly. That lets you look directly at the cells being produced, assess the percentage of blast cells, which is crucial for staging, see if there's any fibrosis or scarring in the marrow, and importantly, it allows for cytogenetic testing.
To look for the Philadelphia chromosome.
Precisely. Cytogenetics like karyotyping or FISH, fluorescence in situ hybridization, can directly detect the Philadelphia chromosome, confirming the diagnosis in about 90% of cases.
And for the other 10%?
Even if the classic Philadelphia chromosome isn't visible, you'd do molecular testing, specifically PCR polymerase chain reaction. This looks for the BCR-ABL1 fusion gene transcript. It's incredibly sensitive.
So PCR can find it even if cytogenetics can't.
Yes, or in cases with variant translocations. PCR is also essential later on for monitoring treatment response, measuring how much of that BCR-ABL1 transcript is left. We call that measuring minimal residual disease, or MRD.
Okay, so CBC, bone marrow biopsy with cytogenetics, and PCR for BCR-ABL1. What about that LAP score you mentioned?
The leukocyte alkaline phosphatase test, it's more of historical interest now, really. It used to be important to differentiate CML, low score, from reactive high white counts, high score, but with genetic testing, it's less critical for diagnosis itself.
Gotcha. Any other tests?
If a stem cell transplant is being considered down the line, you do HLA typing on the patient and potential family donors to check for compatibility.
Right, for transplant matching. And once treatment starts, how is progress tracked? You mentioned PCR.
Yeah, monitoring is vital. We track the cytogenetic response using karyotyping or FISH on the bone marrow to see if the percentage of Phi-positive cells is decreasing. And we track the molecular response very closely using PCR on the blood, looking at the BCR-ABL transcript levels. Ideally, you want those levels to become undetectable, or at least fall below certain thresholds.
Lower levels mean the treatment is working.
Exactly. And if the levels start to rise again, it might signal resistance. That's when you might do BCR-ABL mutation analysis.
To see why it's resistant.
Yep, to check for specific mutations in the BCR-ABL gene that might stop the current drug from working effectively, which helps guide decisions about switching therapy. The frequency of all this monitoring follows specific guidelines, local protocols.
Okay, that's a thorough workup and monitoring plan.
Yeah.
So let's move to management. How is CML treated these days?
The absolute cornerstone of CML treatment is targeted therapy with tyrosine kinase inhibitors, TKIs.
TKIs. They target that BCR-ABL protein.
Directly. They are designed to block the activity of that abnormal BCR-ABL tyrosine kinase, switching off that stuck accelerator.
Clever. What are the main ones?
The first big one was imatinib. Then came second-generation TKIs like dasatinib and nilotinib. Remember the mnemonic?
I'm Dano. Imatinib, dasatinib, nilotinib.
Got it. And there are even newer ones now. In some cases, like resistance or advanced disease, stem cell transplantation might still be an option.
Tell me more about imatinib. It sounds like it was a game changer.
Oh, absolutely revolutionary. It's highly selective for the BCR-ABL kinase. It's usually the first-line treatment, especially for chronic phase CML. The response rates are fantastic.
Oh, yeah.
You can see a complete cytogenetic response, meaning no detectable FIH chromosome in the marrow, and like 69% of patients within a year, and up to 87% by 5 years. It dramatically reduces the risk of progression and has massively improved survival. It really set the standard.
Wow. And the second and third generation ones, nilotinib and dasatinib.
They are generally more potent inhibitors than imatinib. They're often used if someone develops resistance to imatinib or if they can't tolerate its side effects. They can also be options for first-line therapy in some situations. And yes, there are now third-generation TKIs designed specifically to overcome certain resistance mutations.
So options if the first drug stops working, what do the official guidelines, like NICE in the UK, recommend?
NICE generally recommends standard dose imatinib as the first choice for chronic phase CML, but they also say nilotinib and dasatinib can be first-line options too, often considering cost effectiveness.
Right.
For accelerated phase or blast crisis, amitinib is still an option, but often higher doses or second-gen TKIs like nilotinib or dasatinib are preferred, especially if there's resistance. And for really resistant or advanced cases, allogeneic stem cell transplant remains an important consideration.
Okay, a clear pathway. Any new things coming through? Innovations.
Yeah, research is always ongoing. For example, drugs called IRK14 inhibitors are being looked at for imatinib-resistant cases. And another drug, asciminib, is now available for patients with chronic phase CML who've already tried 2 or more TKIs. It works in a slightly different way.
Good to know there's still development happening.
Definitely. But it's crucial, of course, that any treatment decision is made between the patient and their healthcare team, tailored to their specific situation.
Absolutely. Individualized care. So with these amazing TKIs, what's the outlook now? The prognosis.
It's honestly been transformed. Before TKIs, CML was often fatal within a few years. Now, many people with CML can achieve long-term remission.
Really?
Yes, with good adherence to treatment and regular monitoring, a near-normal life expectancy is possible for many, especially those diagnosed in the chronic phase.
That's incredible. So survival rates must have jumped.
Massively. We mentioned the 5-year survival going from around 33% pre-TKIs to over 90% now.
Over 90%.
And 10-year survival went from maybe 11% to around 84%. It's a huge success story for targeted therapy.
It really is.
Yeah.
So achieving that complete cytogenetic response is key.
Yes, that happens in 70–90% of patients on TKIs. And reaching deep molecular responses where the BCR-ABL levels are very low or undetectable by PCR is associated with the best long-term outcomes.
And prognosis depends on a few things.
Right. How well someone responds to the initial TKI, the phase of the disease at diagnosis, chronic phase has the best outlook, and whether any resistance mutations pop up. That mutational analysis helps predict response to different TKIs.
So overall, a much, much brighter picture than before.
Definitely. But like any chronic illness and its treatment, there can be complications.
Right. What are the main ones to be aware of?
The most serious disease-related complication is that transformation to blast crisis, the acute leukemia phase. That's what we always try to prevent with effective TKI therapy.
And side effects from the treatment itself.
TKIs can have side effects, yeah. Things like lowering blood counts, cytopenias, nausea, diarrhea, muscle cramps, fatigue, fluid retention, rashes. They vary between the different TKIs, usually manageable, but sometimes require dose adjustments or switching drugs.
Any long-term concerns with taking TKIs for years?
There's ongoing monitoring for potential long-term effects. Some studies suggest possible links to cardiovascular issues, like effects on blood vessels or the heart with certain TKIs. And like many cancer treatments, there's always a theoretical small risk of secondary malignancies later on, though that seems low with TKIs.
Okay. And the psychological side?
Absolutely. Living with a chronic cancer diagnosis, needing lifelong medication and monitoring, it definitely takes an emotional and psychological toll. Support systems are really important.
Understandable. It's a lot to deal with, even with the improved prognosis. Okay, let's quickly recap those memory aids. We had few bands for symptoms.
Fatigue, easy bruising, weight loss, bone pain, abdominal fullness, night sweats, shortness of breath.
And I'm Donnell for the main TKIs.
Imatinib, dasatinib, nilotinib.
And for the Philadelphia chromosome itself.
You could think 9 to 5, switch at 22. A bit simplistic, but it links chromosome 9, chromosome 22, and the idea of a switch or translocation.
9 to 5, switch at 22. I like it. And maybe some self-test questions.
Yeah, good idea. Ask yourself things like, what is the actual genetic abnormality in CML? Or what are the 3 phases? Or what's the main class of drugs used to treat it and how do they work? Testing yourself really helps lock it in.
Great tips. Well, I think that covers the key ground for chronic myeloid leukemia.
Yeah, quite a journey. So just to summarize, CML, cancer of myeloid cells, driven by that BCR-ABL1 fusion gene from the Philadelphia chromosome.
Right, T922.
Exactly. Treatment revolutionized by TKIs targeting BCR-ABL. Prognosis now vastly improved, often near normal life expectancy possible in chronic phase.
But monitoring is crucial, and potential complications exist, both from the disease and the treatment.
Precisely.
We hope this deep dive has given you, our listener, a really solid, high-yield overview for your revision or just for understanding CML better.
Yeah, hopefully clear and memorable. And if you want more resources for medical exams like the MSRA,
definitely check out pastthemSRA.com.
and for some free questions and materials, there's also freemsra.com.
Great resources. Well, thanks for joining us on this deep dive.
See you next time.